Hi, everyone, and welcome to Cancer Awareness, a new series of discussions brought to you by the Acadiana Advocate. I'm your host, Jill Stokeld. Today, we're going to be talking about something that affects so many lives, cancer. But more importantly, we're going to talk about the advanced, hopeful care and treatment that's available right here at home. Joining us today is Dr. Henry Kaufman, a board-certified surgical oncologist and a leading expert in cancer care right here in Acadiana. He's trained at some of the top medical centers across the country, and he has shaped the care at Our Lady of Lourdes, and where he is known for not only his skill, but also his compassion. We'll talk about how cancer treatment has changed and evolved over the years, and what's available besides just the traditional chemotherapy, and how important it is to have treatment available surrounded by family, your community, and what a difference it really does make. Dr. Kaufman, thank you so much for joining us today.
Thank you for having me.
You ready to get started?
Absolutely.
Okay. You have dedicated your career to fighting cancer. And I can only imagine when someone gets the news that they have cancer, that just the overwhelming feeling that must come over them. Could you talk about how the treatments and advancements have changed the therapy, especially over the last 30 years, and why people might have more reason for hope today than they did from perceptions from the past?
Absolutely. So cancer care is rapidly evolving, even on if not a daily, monthly basis, certainly on an annual basis. It evolves so quickly, in fact, that the world's experts in every individual arena of cancer get together every 2 years and re-update cancer treatment guidelines based upon the most recent data that's come out. And some people have even proposed that maybe that 2-year interval is not enough right now with all the new technology and therapies coming available. There are things available now that we only dreamed about 30 years ago. Literally, people were brainstorming and throwing out crazy ideas in regards to cancer treatment. You know, maybe we could design a virus that we can inject into a cancer that killed it. And I was like, well, that's interesting, but how are you going to make that work? Well, you know, here we are in 2025, and not only do we have it, but it's remarkably effective. We've developed therapies where we can take the body's immune cells out, program them specifically to fight their cancer, put them back in, and just have them devastate the cancer. Remarkable things. And then now we have more generalized therapies available. There are chemotherapeutic agents available that are not the traditional toxic chemotherapies that we take, but rather immune system modulating agents that unleash the potential of the immune system, if you will, turning them more aggressively toward the cancer. And we're seeing results in response to that are so dramatic that we're having to change our entire paradigm of how we deal with cancer surgically and with other therapeutic options. So it's an exciting time to be in cancer care right now.
Yes.
We're able to take care of some problems that traditionally we used to just have to have a very heartfelt and sad conversation about. And we're offering hope and options to a lot of people that it just wasn't there before. That's being reflected in the overall trends that we've been seeing over the last 20 years, which is a slight decrease in cancer incidence, especially as, you know, smoking becomes a little bit less common. But even significantly more than that is survival from cancer has improved dramatically in the last 20 years. Early detection certainly has a lot to do with that.
Right.
But the therapeutic options available, even for late-stage cancer now, have really changed survival for the better.
That's amazing and such great news to hear. And like you said, for someone who's been around for 30 years, it does. I mean, just even when, you know, friends and family get the diagnosis, their whole outlook is completely changed.
Absolutely.
So when you hear cancer treatment, we were just kind of talking about this, but maybe you could expand a little bit more, is that, you know, most people think chemotherapy is the first thing that comes to mind. But like with all the advancements, what are some of the other, I know you mentioned the viral treatment, et cetera,
Absolutely.
but like, you know, maybe there's some other options that people aren't even aware of that are out there today.
So I'll give you a great example. Back in the 80s and 90s, we realized as a medical community that we had a bad problem with childhood leukemia, that we had a lot of kids with leukemia, and we really didn't have any options available for them. right about that same time, computer modeling was getting robust and sophisticated enough that we could start modeling pharmaceuticals in computer simulations. And so a lot of money and research went into leukemia. As a result of that, we realized that one of the primary drivers of a lot of childhood leukemia is an enzymatic pathway called tyrosine kinase. And when you turn tyrosine kinase on, it's like opening up the governor to the cell. The engine just starts revving at 100%, and it's hard to turn it down. It's think of it like a runaway engine. And so what the scientific community was able to do is go into the lab, model this enzyme, and then come up with something to jam in that enzyme and block it that wasn't going to be toxic, that didn't interact with other human enzymes. And this drug was called a tyrosine kinase inhibitor. It was sold, marketed in the brain, Gleevec. And it was the first silver bullet, computer modeled, targeted cancer therapy that we had. It basically was a pill that you had to take once a day. And we were able to almost, dramatically revolutionize the way that we treated leukemia almost overnight. And so we started looking at a bunch of other cancers and said, are there other cancers where tyrosine kinase pathways are involved? And certainly there are, but none that were the major drivers like leukemia, with one exception. And there's a rare intestinal sarcoma called gastrointestinal stromal tumors, which I do see a fair number of, unfortunately. But now we have this therapy that was developed for leukemia that's also highly effective. I've had patients with stage 4 gastrointestinal stromal tumor on Gleevec. They take one pill a day. They've taken it for the last 20 years or 17 years, however long the drug's been out, and their disease has gone away, melted, and they're doing fine. Our goal is to find a therapy like that for every cancer. And what we have to understand is that every cancer is different. Every cancer has different pathways. Not all of them are just going to have one thing that we can target and treat. But as we work through these things and find where the targets are, we can develop specific therapies for them. And that's the future of cancer care.
Wow. It's amazing. It truly is. And I know one of the key messages you wanted to share with our viewers today is that the residents of Acadiana do not have to travel far and wide to receive world-class cancer care, that it's available right here. So what capabilities and expertise do we have right now at Our Lady of Lourdes?
So 40 years ago, cancer care was not standardized across the United States, and it was certainly not standardized across the world. And as I mentioned, world's experts getting together every 2 years and looking at all the data that's come out, coming up with guidelines in regards to care. That's called the National Comprehensive Cancer Network. And the NCCN has up-to-date guidelines based on the best scientific evidence and the best available treatments in regards to how we treat cancer. Now, things are coming out so fast, sometimes you could actually be a little bit ahead of that if you're keeping up with the current studies. But almost all cancer treating physicians across the United States follow those guidelines. So whereas there used to be huge regional and local differences in how cancer was delivered, now it's become fairly standardized. I had a patient that saw me not too long ago from Belgium. Husband was an oil field worker. She was in Belgium and unfortunately had a diagnosis of breast cancer and was treated by surgeons over there. The reports I got back, both from the operative report, the path report, the cancer synoptic report, and her medical oncologist recommendations were identical to what we would see in the United States, including their format and almost their typeset, with the exception that everything was in French. And it was encouraging to see that we're all doing it the same way because this is what works best. Fortunately, in Acadiana, we now have comprehensive cancer services and have for quite some time. We're 20 years now into a significant depth in regards to medical oncologists. And in fact, medical oncologists, not only that are generalists, but they also specify and have dedicated themselves to specific areas of cancer treatment. Radiation oncologists, we have some fantastic radiation oncologists here. We have state-of-the-art radiation oncology units here locally, best in class for sure. And we also have great surgical oncologists who were well-trained in NCCN designated institutions, that wanted to come back to Acadiana to try and deliver needed and necessary care here. So we've got everything now soup to nuts. It's been in place for 20 years. And I think that we've got a fantastic track record of showing that we can provide care at the highest level, because when you're 2 hours or 2.5 hours down the road from the best cancer institution in the world, you've got to be at the top of your game to compete. And I think we're there.
That's awesome.
Yeah.
Yeah, because, the medical treatment itself is, of course, important. But for the patients to be able to receive the care close to home, where you have your family, your friends, the food you're familiar with, your own bed, your support systems, like, what does that mean? I mean, what sort of impact does that have on the patient and their family unit?
It has a huge impact. Your emotional well-being, your ability to stay strong, mentally strong to get through the fight. I see a lot of cancer patients who have early disease, and, unfortunately, I'm able to tell them, like, look, this isn't going to be a major health crisis. This is going to be a big inconvenience to you, and at the end of it, you're going to be fine. But sometimes I have to have that opposite conversation. And sometimes I have to tell these patients, like, look, you are in the fight of your life, okay? We got a lot of hurdles to get over, but I can see a light at the end of the tunnel. And I'm happy to bring you there, but these are the things that we're going to have to do. And then I rope everybody into it, right? Mom, wife, sister, brother, everybody, hey, this is what we need to do. This is the pathway we're going to take. I need all you guys. I need all hands on deck and everybody helping out. Having that support structure and having that help getting that patient through their cancer journey is critical. And without it, some people can't make it. And unfortunately, we run across people sometimes that don't have adequate support networks to get them through some complex therapies. And it can be a real challenge to take care of those patients. So being home in comfortable and familiar settings with all your people around you and supporting you, it's hard to beat that.
Yes, absolutely. And I know that Our Lady of Lourdes has moved towards treating the whole person, like, obviously, rallying the troops, if you will, of the family, but also, not just the cancer, but, like, what are your thoughts on comprehensive support services that are offered to the patients?
No, absolutely. I think that fits right in with what we were just discussing. Mm-hmm. A lot of us, unfortunately, over the course of our lives have neglected our health, or maybe not spent as much time taking care of ourselves. And I get it. I understand that 100%. Up until the age of 50, if you ignore something, on odds, it's going to go away. After the age of 50, things start to change a little bit. And sometimes when someone comes up with a cancer diagnosis, we end up finding other things and medical things that need to be taken care of and address those issues. Getting the patient in optimal health, their overall general health, nutritionally, from an exercise standpoint. I think sometimes I spend just as much time working with the patients in regards to diet, nutrition, starting good, healthy exercise habit. And most of the patients, remarkably nowadays, that I operate on don't go straight to surgery. Most of them, from my big complex cancer cases, are getting treatment first. The person that we end up with before operate on at the end of their chemotherapy journey is often much healthier than the person that we started off with. And so the public's general perception of chemotherapy is often driven by movies and fiction and media, because when you want a patient that when you want a character in a production that you can empathize with, very easy way is just give them cancer, right? And the more miserable you make that patient, the more the audience tends to empathize with that patient.
Absolutely.
But a lot of what we're used to thinking about as far as how cancer goes is just not there anymore. What I tell patients in regards to their treatment is this isn't going to be a walk in the park. It's not going to be fun. But the one thing I can promise you is it's not nearly going to be as bad as you think it's going to be. And the patients come out of it and they almost universally tell me that. Like, you told me that and I didn't believe you and it wasn't fun and I don't want to do this anymore. But no, it wasn't nearly as bad as you thought it was going to be. So if I can take a patient and work with other healthcare providers and have that patient at the end of their treatment be even healthier and better than they were before, that speaks to where we are in regards to cancer care.
That's it's amazing. And it kind of segues into like the next thing I wanted to talk to you about is that, you're a surgical oncologist. So how do you coordinate with medical oncologists and the other specialists to determine the best course of treatment for the patient? Like you said, implementing healthy habits, et cetera.
Absolutely.
So, and then like, especially regarding the timing of surgery, because you also said, I see now more days that people don't go immediately to surgery. So what all factors into making those kind of decisions for the best course of treatment?
So as the surgical oncologist, a lot of times I end up being the gatekeeper in regards to this. And so my role in a lot of patients' cancer care is when they show up with a problem or we find something on a scan, number one, determining the best way to get a diagnosis, and I'll often take an active role in that surgically in order to obtain tissue so we can move forward. But then after that, it's trying to select the best way moving forward. More often than not, it's very clear. Based upon appearance of x-rays and other things, when a patient has a more advanced cancer, when it's not early stages, what we've realized is that treating them up front with chemotherapy and sometimes radiation and sometimes other therapies can often have a dramatic impact on my ultimate ability to clear their disease surgically. And so the entire goal is to get that patient to the point where they can tolerate and undergo an operation where we can completely eliminate their disease. To get us there often means that we're going to have to do some treatment up front. And we make those decisions in concert. And you're like, well, how do we coordinate care? And I was thinking lots and lots and lots of conversations. Fortunately, we're all speaking the same language. And I think it was our second day of medical school after they told us our locker combinations and what our schedule was, that a wise physician, and I think I'm almost certain he was a surgeon, came in and explained to us that medicine is an entirely separate language, that we're going to learn and become fluent in this language of medicine. And not only is language a separate medicine, but each specialty kind of has its own way, its own language, its own way of saying things. Myself and my medical oncology colleagues and my radiation colleagues, we're all very fluent in the same language of cancer care. And so we've been doing this together long enough that we can almost finish each other's sentences. People ask me, well, what is this doctor, will you talk to that doctor and ask him what he thinks about this? I'm like, yes, absolutely. We're going to 100% discuss your case. But I'll tell you, we've done this together so many times. I know how he thinks about it, and I know he's going to be on board. And I think we're all in agreement this is going to be the best option for you. So lots of discussions, lots of coordination. And then once we decide upon a pathway, we all work together to get that patient there. And so a lot of times it involves me making sure the patient has adequate access to get their treatment, them then being coordinated with medical oncology then coordinating and overlapping with radiation oncology, and then those guys keeping up with me so that I know when they're going to finish their treatment, so I can then carefully time out the optimal timing of their surgery so they can recover from their treatment, but not wait too long that the cancer starts to progress again before we jump in surgically.
That's great. I love the kind of the team approach.
It's 100% a team approach.
Yes.
Absolutely.
And so, because you're the surgical expert dealing with the medical oncologist, it makes perfect sense to make sure that you're getting the best outcomes possible for your patients.
Absolutely. And I can't tell you how satisfying it is to work with a group of really world-class people who are at the top of their game. We teach each other things every day. I can't keep up with the entire body of medical oncology literature. I dabble in it, try and learn as much as I can.
You know the language.
My goal is making sure I'm an expert in everything surgical oncology. So I learn things from my medical oncology and my radiation oncology colleagues every day, and I try to reciprocate as best as I can as well.
That's great.
Yeah.
I love it. So cancer surgery itself has seen remarkable advancements. Can you discuss some of the key evolutions in surgical techniques that you're implementing for your patients here in Acadiana?
Absolutely. So I'm trying to think about my timeline. I finished medical school in 1997. So we are now talking about 28 years ago. Wow, that's amazing.
I know, don't say it out loud.
Yeah.
I mean,
When I started my residency, the first case that I did or assisted with was an open surgical procedure. That being said, that was the era in which I was training. It was the era of open surgical procedures. However, it was on the cusp where laparoscopic, minimally invasive surgery was coming on board. And I spent a significant portion of my surgical training doing open surgery, but also at the same time, almost as much laparoscopic surgery. So that when I finished at University of Tennessee, Chattanooga, I felt like I had good advanced laparoscopy skills, so that when I showed up at Ohio State, even though they were experts in cancer care, they weren't experts in minimally invasive surgery. And in fact, I went through and taught a lot of their surgeons how to do minimally invasive colon resections and other type of surgical resections. And so that's the great thing about moving around, going to different institutions. You see different ways of doing it, and you acquire knowledge from everybody that comes in. The first 10 to 12 years of my surgical career in Lafayette were spent doing minimally invasive surgery laparoscopically. The robot had been around during that period of time, but it hadn't, the company had not developed the techniques and the equipment to make it really adequate for complex cancer surgery. That all changed about 10 years ago. When the most recent generation of robot came out, it had the tools that we needed to start applying those laparoscopic skills to robotic surgery. We didn't know if it was going to be a big change, but we thought it could be, and we thought it could push us to the point where we could do more complex operations. Fortunately, it was all that and more. What we've seen with the advent of robotic surgery is significant increase in operating room times. The operations take much longer because we're working on a much finer, much smaller scale. The blood loss is much less. The physiological disturbance on the patient is much less, and the patients are recovering remarkably quicker. So complication rates have gone down. Narcotic use after surgery, in some cases, is almost eliminated. People are so comfortable they're not needing to take pain medication, and they're recovering from surgeries quicker than I ever thought possible as a surgeon. We are doing some pretty remarkable things to people. And I used to tell the open surgery patients, you're going to be in the hospital a week or 10 days. The reason is not that you're going to be that sick, but just the reflexes of operating on you are going to cause your intestines to shut down. It's going to take me 7 to 10 days to wait until your intestinal tract wakes up, till I can feed you and make sure you're comfortable and you can take your medications. Something about minimally invasive surgery, especially with the robot, eliminates a lot of that. And so people are recovering remarkably quicker. They're getting home, and they're not being pushed out of the door. They're standing in the doorway of their room dressed when I come up there saying, "Can I go home? I'm ready. This is great. What do you need me to do?" And so it's really revolutionized surgery. Now, it's put a little bit more strain on the surgeons in the operating room because this very expensive technology with a lot of enhanced complexity can take 50% or so longer to do some of these cases. But the downstream benefits and outcomes for the patients are truly extraordinary, and it's changing the whole paradigm of how we deliver care.
The mere fact, because, again, as someone who's been around for more than 30 years, I remember visiting friends and family after a surgery, and they were in there for a week or so. But now, just to be able to go home and not have as large of a scar and everything, there's so many rewards to that.
Yeah, it even as a surgeon, it amazes me every day how much things have advanced and how they continue to improve. It's really remarkable times that we're living in.
Absolutely, it is, and thank goodness we're here.
Yes.
We hear the phrase, numbers matter in specialized medicine all the time. And you treat over 40 different types of cancer every month. So how does the breadth and depth of your knowledge and experience benefit your patients?
Wow. So cancer fascinates me. The care of cancer fascinates me. Novel ways of addressing difficult problems fascinate me and excite me. And so I think that the challenges that are brought forth by dealing with different cancers routinely is what keeps me engaged in this. It's not uncommon for a patient to be in my office and to say, this is such a rare cancer. Have you ever seen this before? And I was like, you passed 2 people on the way out of here with this rare cancer. You just happen to be coming in on the same day. I see weird, rare, unusual things every day. And the reason is that there are so many weird, rare, unusual things out there that they're going to pop up. When you're learning about these things in medical school, you're thinking you're never going to see them, that they're just testing you on these things because they have to find something to differentiate the class and figure out, the true depth of your knowledge. But truly, when you're dealing with a population of 1.5 million people, anything that can occur to that population is going to pop up, and we certainly see it. And so a mentor of mine once told me that, your value as a surgeon is predicated a lot upon your skill set and what you can offer the patient in that regards. But your value as a physician is often going to be dictated by how deep the depth of your differential diagnosis is. So how far down on the uncommon list can you go before you start running out of room? And so I've always tried to make sure that that list is as deep as I can possibly make it. And so that every time I encounter something I haven't seen before, that before I'm done with that, I'm an expert in that area. And so I think that has served me well over the years.
Absolutely. Yeah. It's comforting to know that, again, you just have the experience and you've treated all of these various types and do it on a regular basis.
Absolutely.
And just reaffirming, becoming an expert. Okay. We all hear about early detection and how critical and crucial that it is, especially for like aggressive cancers, maybe such as pancreatic cancer. Mm-hmm. What message do you have for our viewers about screening and recognizing potential warning signs?
I'm so glad you asked me that. And I'll start with one example. I'll see on average about 5 new breast cancer patients every day. The first question I ask that patient is, how did we find this cancer? If they tell me that they find that cancer on a routine screening mammogram, then I know exactly the direction that the visit's going to take. There's a high likelihood that at the end of my assessment of that patient, that I'll be able to tell them, hey, it's cancer and we're going to take it seriously. But at the end of the day, this isn't going to be a major health crisis for you. You're going to live a normal life. You're not going to be disabled. And you're going to look back on this as a huge, not health crisis, but rather just a huge inconvenience. That's our goal with care. If we follow routine screening recommendations for breast, colon, prostate, and other things, we're going to find these problems early, and we're going to be able to take care of them so much easier for the patients. It's night and day in regards to the presentation and what we can offer for modern medicine. Unfortunately, there's still a lot of cancers out there that if discovered in a late stage, we're limited in regards to our options. But there aren't many cancers out there that we can't cure in their early stages. So keeping up with your primary care provider, routine mammography, getting your PSA levels checked. And probably for Acadiana, probably the most important thing to know is that we don't do well with colon cancer. Everybody thinks that we have a high cancer rate here in Acadiana. And our cancer rate is not significantly different from the rest of the nation if you remove smoking as a cause. All causes on board, the only thing that we really have a higher rate is with colon and rectal cancer. And if we did better as a community with screening of individuals, we would be able to not only identify cancers earlier, but identify polyps and remove those polyps before they ever become a cancer. So part of what colonoscopy screening is about is not only about detecting the cancer at an early stage, but in a lot of people, getting to it before it even becomes a cancer and removing it as a problem. I would like nothing better than to never, ever have to do another colon resection again. And I think that if we were perfect with colonoscopy screening and removal of polyps, that there's a good chance we could get close to that. So if I had to ask anything for my fellow Acadians to do, it'd be to just make sure they keep up with their routine screening.
Right. Because I've always heard, and I mean, I'm a layperson, but that colon cancer is one of the most treatable cancers if it's caught early.
Absolutely. It's one of the most treatable cancers in general, but a fairly low risk, straightforward polypectomy at the time of endoscopy, if not that, then a relatively straightforward surgery can be curative with no further treatment. Once that cancer's gotten out of the colon and into adjacent lymph nodes or remote structures, then it starts becoming a significant challenge. And we can still cure some of those people, and we can certainly buy them years, but those years are often under the care of physicians and undergoing treatments those people would probably rather not have to go through.
Right. Right. Okay, Dr. Kaufman, your patient ratings are outstanding. And some of the things that they are talking about is how clearly you explain things, which I can testify to after talking with you briefly today, and that how much care and compassion that you show towards your patients. What does it mean personally to you to be able to provide this high level of care and treatment to the people of Acadiana, your home community?
I think I'm very blessed that circumstances resulted in my ability to go out and get top-level cancer training and work in a bunch of great institutions and then bring that knowledge back to Louisiana. When I was a medical student, looking at how patients were treated, we all start out very idealistic. And it is very easy, unfortunately, in a rigorous environment without a lot of sleep, with a lot of stress, to become desensitized to that and to become cynical and jaded. And I will tell you that it requires no small amount of effort on a daily basis to try and make sure I don't get to that place.
I'm sure. Well, you're doing remarkably well. I can testify to that.
Well, thank you.
Okay, we understand that you were the chief medical officer at Our Lady of Lourdes during the COVID-19 pandemic. How did that experience either reshape or affirm how, you go about hospital management and patient care, the approach to all of that, and what lasting changes have you seen in how healthcare is delivered?
Wow. So the COVID pandemic was not fun for anybody, and it was probably a lot of people suffered significant health consequences, and the hospitals were put under considerable strain. The way that my colleagues came together and put their own health and needs aside for the care of the community was remarkable. It restored my faith in medicine. It reminded us all of why we went into this, and seeing people pull together as a team under stress was remarkably satisfying, and I felt blessed to be able to work with such a group of individuals.
All for a great common cause.
Absolutely.
In horrible situations.
Yes.
Love it. All right. So finally, what gives you the most hope for the future about cancer care, both for your patients and for the world of oncology as a whole?
I think that we have some truly remarkable people working right now in designated NCCN and other labs toward delivering these unique novel types of cancer therapy. Some of the things that I've heard coming down the pike are truly remarkable. Imaging, we've all heard about PET scans. Imaging, we now think that before long we're going to have unique imaging modalities where specific types of cancer can be highlighted. Not only will we maybe be able to highlight the cancer, but we'll also maybe be able to take therapeutics and tag them to those agents that highlight it, and specifically target very minute areas of cancer. Our understanding of the immune system and the complexities of the immune system is rapidly evolving. Understanding how to manipulate the immune system to our advantage without harming the patient has come a remarkably long way, and I think a lot of doors are about to be opened there. And then we are right now, as of this year, in an era of novel genetic therapy where for the first time, CRISPR technology has been used to cure genetic diseases. and it's not going to be long before we're using CRISPR to go in and specifically attack cancer. And I think great things are coming along. Sometimes things are happening so rapidly right now that when we talk to patients about why we're doing aggressive care and what we're working toward, sometimes we tell them, look, today, I don't have a cure for what you have, but I think I can buy you a number of years, and that may be enough to bridge the gap till we do have a cure for you. So let's push forward and see what we can get done. And remarkably, that works out sometimes, where things that weren't available for cure become available, and people have remarkable results. And so we'll keep pushing as long as we can.
Thank you, Dr. Kaufman. It has been an absolute pleasure speaking with you today and learning a little bit more about the advancements in treatment and how much hope there is out there for patients and their families, and that it's available to everyone right here in Acadiana.
Absolutely. Happy to be here.
Really appreciate it.
You're very welcome.
So this was the first installment of our new series, Cancer Awareness, brought to you by the Acadiana Advocate. Please be on the lookout for our next installment.